Then here's another entity, even low power, which catch our eye, this bubbly cell. It seems just around the hair follicle, but we just have too many this structure. This is sebaceous gland. So when we have more sebaceous gland than usual, we have our differential. This one just sebaceous hyperplasia. Why another one is sebaceous adenoma or maybe sebaceoma. How could we tell them apart? First, for sebaceous hyperplasia, this sebaceous gland just hugging a hair follicle. And then when we have high power, we just can see most of these structure just sebaceous cells. And then in the periphery, we do not see germinative stem cell. That means germinative stem cell, just like this cell, usually in sebaceous hyperplasia, just single layer of this hyperchromatic basaloid cell. If we have several multiple layer, that is at least sebaceous adenoma. So this one just sebaceous hyperplasia. And then we have sebaceous adenoma. This is sebaceous adenoma. First, we know that this sebaceous can not just surround the hair follicle. They just everywhere. Then, even low power, we know other than this bubbly sebaceous gland, we have kind of multi-layer of this hyperchromatic, multi-layer bluish basaloid cell. When we zoom in, yes, we can see not just sebaceous differentiation around. We also have this hyperchromatic cell, multiple layer of them. And then when you call this sebaceous adenoma, that means we have more than 50% of this clear sebaceous well differentiated sebaceous cells. If we have more this primitive germinative basaloid cell, more than 50%, we call that sebaceoma. And then you need to bear in mind that for this sebaceous adenoma and sebaceoma, we need to see kind of well circumscribed. We could not see that infiltrated growth. And then when we see the cytology, sometimes you may see mitosis, but you could not see atypical mitosis. Kind of a little bit atypia, but not dramatic atypia. This is Sebaceoma. Even low power, we can tell we have some kind of sebaceous differentiation, bubbly cell, but other than that, we have more of this basaloid, primitive, hyperchromatic cells around. But the overall architecture kind of draw a line here, kind of symmetric, well, kind of circumscribed, and then higher power, we really look for any dramatic atypia. We have a little bit atypia, but not really dramatic. And then occasionally you may find mitotic figure, just like this one, really clear mitotic figure. But not infiltrated growth, not really dramatic atypia. And then you should not find any atypical mitosis. So this one is Sebaceoma. Then we have this sebaceous carcinoma. This lesion is really big. Even in this part, we can see the lesion kind of like dissected. So you can estimate this is really infiltrated lesion. And then really dark, really hypercellular, hyperchromatic. And then in some area, we can still see this sebaceous differentiation. But when we see this cell with this stroma kind of infiltrated growth, then let's see the cytology of this cell. With some cell is really big, really hyperchromatic, just atypia just make you think of it should not be benign entity in combination of the infiltrated growth. This slide is not that really high resolution. But you can see this cell is kind of really atypical, really big compared to this one. So you need to think of sebaceous carcinoma. And then when you have multiple of these sebaceous adenoma, sebaceoma, sebaceous carcinoma, and this lesion usually happen in the face, head and neck area. If you have multiple, you do need to think about Muir-Torre syndrome. That is another variant of a small subset variant of Lynch syndrome. So you can do your microsatellite marker MLH1, MSH6, MSH2, PMS2 to just screen to Muir-Torre syndrome. And then especially if you see sebaceous adenoma, sebaceous sebaceoma, sebaceous carcinoma out of head and neck area. Even one single lesion, really highly suspicious for Muir-Torre syndrome. But sebaceous hyperplasia is not foreign to the Muir-Torre entity. So if you think that is sebaceous hyperplasia, that's totally benign, not related to any syndrome.